Well, good evening, everybody. Those of you that have joined us, hope you're going to find tonight's webinar with Andrew about intraosseous anaesthesia interesting and informative. Swallow Dental were introduced to the concept in early 2019, and while it seems to be extremely popular on the continent, France in particular, it's yet to really catch on here in the UK. I remember at the time we were really excited. It seemed like a really logical progression from routine infiltrations and ID blocks, and just had so many advantages, and not only over manual syringes but also the electronic syringes that were on the market at the time. So, being guinea pig personally on a number of our training courses, I can absolutely say from experience that as a patient, it is a huge improvement. And also talking to the doctors who do use the system already routinely, it's a massive practice builder and a time saver too. So please feel free to use the Q&A at the top of the screen to put forward any questions as we go. And what we'll do is we'll try and address all of these at the end of the presentation. So I'll pass you over to Andrew, and we can get going. Thank you.
Thank you, James, very much indeed. Good evening, everyone. I really appreciate you coming out on a Thursday evening after a hard day's work. I'm going to be as efficient and swift as I could possibly be this evening. So, as James said, we can save some questions till the end, and James will accumulate those and moderate those as we go along. But tonight I do want to talk to you about something that has been a complete life changer in my practicing career. And I want to try and make that really clear to you. My name is Dr. Andrew Prynne. I am a general dental practitioner based on the south coast of the UK. I have been working there, or had worked there for 35 years. And the last 14 of those years were particularly special because 14 years ago, I was introduced to the concept of intraosseous anaesthesia. And I can tell you now, it completely changed everything I did for the benefit of my patients, primarily. Myself, I will be very honest with you, completely changed my stress levels, my outlook on dentistry. My team around me made a huge difference to them, as hopefully I'll show tonight, but also to the business of dentistry, our dental business. So I'd like to start with just a look at what anaesthesia is. Anaesthesia is essential for us. Without anaesthesia, we can't form a relationship with our patients. We would not be able to do the treatment we do. And it's been a concept for many, number of centuries. But recently, new technologies which have been proven have come along and have made a huge difference. And I want to focus on the concepts of electronic assistance to the anaesthetic delivery, as well as specifically intraosseous techniques. I'm addicted to change. I love things that change, and the difference that it made to my practice was augmented by the fact that I threw myself bodily at this as a concept, to the point where, as I opened the box and my new device, I instructed the team to take all of my manual syringes, put them in a little Tupperware box, and take them somewhere in the practice that I didn't know where it was. And as I walked out of the practice for the last time a couple of years ago, I still don't know where they went. And I've been using the system ever since. I represent the Dentalhitec Academy. I am not part of any sales process, and I am here constantly to support you and all of your colleagues in the development of this concept within your own practicing life. So dental anaesthesia has been around for a long time, and at the end of the 19th century, our colleagues back then would have been using something like this. And I find it staggering that up to 14 years ago, and dentists right now, for all very good reasons, are still using what is effectively the same device. Now, don't get me wrong, even myself, I felt myself very adept and very skilled at providing completely painless injections. With the skills we learn over the time and the experience we get, we can create painless injections with this, and that is fine. However, local anesthetic with traditional syringes definitely has a dark side to it. There are negative aspects that run right through the whole system. And I'd like to just try and elaborate first on those. What is wrong with traditional techniques? Time. Time is probably our most valuable asset, and all traditional techniques involve a degree of waiting before that anesthetic takes effect. Control of patient movement. I'm not surprised that where you get a long device such as a manual syringe and your arm is literally, well, not literally, but metaphorically 1.5 miles away, it could be 1.5 miles away, because the control over that fine needle tip is minimal with that degree of flexibility and leverage. After a traditional anesthetic into soft tissues, the patient will have a collateral numbness of their face, including motor function loss. And that is quite debilitating in certain situations and distressing in others. Multiple appointments are not possible, or should I say are required for bilateral mandibular treatments. Unless we really don't like our patients, we're not going to give bilateral mandibular blocks. The patient effectively won't know where their head's gone. So we have to break those down into separate appointments, which is time consuming, and as a result is a very negative aspect of this. Stress cannot be underestimated. My stress levels, I've already said, just plummeted when I first started using this system, because I knew I was not going to give my patients any pain any longer. But it's not just the patients, it's the dentist, but also the dental team, the hygienists who, as we know, have to sometimes wait while a dentist overruns, the dental staff in the front office, the reception team, our front face of our businesses, some of the most important people we have. They have to manage patient frustrations and expectations out there at the desk, and this can have a knock-on effect right the way through our businesses. And then there's the biggie. There is failed anesthesias, which really happen. I think we all have suffered with those, and particularly with the concept of the inferior dental block. Now, statistically, this is the most common dental anesthetic failure. And the hot mandibular molar is probably our biggest nemesis. Now, what innervates our hot mandibular molar? Well, primarily, it is the inferior dental nerve. So that is why we give a block to cut that nerve off. But there is also, and inconsistently, there is the buccal nerve, the mylohyoid, the lingual, the auriculotemporal, the 7th cranial nerve, the 9th cranial nerve, and the superficial cervical plexus, who've all been shown to innervate teeth with random fibers. Now, Professor Johann Apps did a superb bit of work based on CT scans and anatomy, and he demonstrated clearly that 95% of us humans have at least one accessory canal able to bring in any of these fibers from the other nerves. And in those 95% of patients, they can have up to 11 in any one jaw. So this is significant. We can completely switch off the inferior alveolar nerve, and yet still the patient feels it. It's not the doctor's fault. It's not the dentist's fault. And a good analogy to use with the complexity is the complex wiring around a domestic consumer unit. We know, however, with a domestic consumer unit, that if you remove one wire or cut one wire, you will shut off that circuit. Not the same in human beings. And Prof. Apps concluded that neurovascular bundles that are not originating from the mandibular nerve can and will only be anesthetized if anesthetic is injected directly into the cancellous bone. So what are we looking to achieve? What are we looking to anesthetize? I put it to you that the last common denominator is where the nerve enters that tooth, the dental tissues that we are going to be treating. And that could be a nerve, as we've just shown, from a number of different sources. So the apex is where we want to focus. Now I'm going to break this down into a couple of phases now, as I said at the beginning: electronic delivery and intraosseous anaesthesia. Now, the concept of electronic delivery, I will admit to you, I thought was a complete gimmick when I first was introduced to dental pens that do this job. I thought it was just a mildly lazy thing where dentists didn't want to use their thumbs to press the plunger. But how wrong was I? Let me show you. The significance here lies in the speed of delivery. Now, with a manual delivery, we are placing a bolus of anaesthetic into the soft tissues. However carefully we think we're injecting that, we will be injecting solution beyond the point at which the vasoconstrictor has been able to work, especially in the dental soft tissues. That has two concepts that are negative. The first is that you get a more diffuse, a less concentrated anaesthetic effect where you want it, but you also get a much bigger area of collateral numbness. Now let's compare that with intraosseous anaesthesia or with electronic control. With the electronic control, with a very slow initial delivery, you will end up with the first drops of anaesthetic creating the vasoconstrictor effect we want with the adrenaline in that solution. That means that, again, two things. The anaesthetic effect is much, much more concentrated where we want it, but also that extent of collateral numbness is significantly reduced. So these are the effects of electronic anaesthesia, which I had not appreciated till I started using it. So intraosseous anaesthesia now is where we're going to focus the primary part of our completely pain-free, reliable, predictable anaesthetic. The benefits of intraosseous anaesthesia lie in the immediate success, even for the nemesis, the hot mandibular molar. Stressless and painless, these are real features. And I can't, as I said, emphasize the stress reduction enough when you know it's going to work. We're going to eliminate the concept of the numbness in the face. Patient will finish with no feeling of numbness in their face. From a business point of view, that means that you get very, very happy patients. Their loyalty is enhanced, and they will go and they will talk to others, and it is a great practice builder. Your management of appointments can be vastly enhanced because effectively you know how long it's going to take. There's going to be no waiting around and no potential for that failure that I referred to earlier. And this will lead to increased profitability thanks to the time saving, which is significant. Now, intraosseous anaesthesia is not a new concept at all. Back in 1906, Dr. Nogi in France, he described in the literature diploic anaesthesia. And what he was talking about were two cortical plates, which in the dental alveolar structure is effectively a chamber, a box. And he said back in 1906 that if you can fill up that chamber with anaesthetic solution, he said analgesia is immediate and absolute. So it's not a new concept. Let me take you through how we now can deliver intraosseous anaesthesia. Using a very special needle, a very shallow angle, drop by drop delivery of solution placed at the base of the interdental papilla, that creates a residual blanching. That blanching will indicate that the periosteum beneath it, directly beneath it, is anaesthetized. Reorientation of the same needle, positive contact with bone, pain-free, and the needle will rotate gently, and it will just deliver itself very lightly through the cortical plate into the cancellous bone. When it is in the cancellous bone, then the electronic delivery can ramp up very gently the delivery of the appropriate volume of anaesthetic solution. This effectively is the way to complete serenity. Now, many thanks to Dr. Santosh Patil, who has provided some superb photographs here, but clinically the view would be stage 1, which would be the blanching of the mucosa. Stage 2 would be the reorientation and the delivery of the needle through the cortical plate into the cancellous bone, followed smoothly on by the electronic delivery of the anaesthetic solution. There are many paradigms to get round here. We have always looked at the midline as a cutoff. If we had a tooth to treat on the patient's right, we wouldn't be giving injections on the left because the nerves effectively don't cross the midline. That's a thing of the past because effectively the mandibular bone is continuous. So if you were treating a tooth on the right, but you couldn't deliver anaesthetic solution into that due to perhaps pathology or maybe the anatomy, the roots were too close together, it's not a problem. You just find another area, which can be the other side of the mouth, deliver the solution into that bone, and that will diffuse across and make a profound, instant and deep anaesthesia predictable. So the midline is no longer an issue. Full mandibular anaesthesia can be gained then by placement of anaesthetic solution in 3 sites. For periodontal work, this is effectively turning off the all of the sensitivity in those teeth very, very easily. Similarly, in the maxilla, 3 sites, subtly different, but they are still in the maxillary bone, and that will create a complete mandibular full arch anaesthesia. Now, there is no need in this system for a second injection. No supplementary injections at all. How is this possible? Well, again, I'll go back to animations. In an infiltration anaesthesia, a bolus of solution is delivered external to the cortical plate. Through the Haversian system and the Volkmann canals, this solution will diffuse through that cortical plate and into the cancellous bone. So an infiltration anaesthesia is in effect an intraosseous anaesthesia, but you have got this bolus on the external surface. It's a less concentrated anaesthetic effect, and you will have a lot of collateral numbness. Let's compare that with intraosseous anaesthesia, where you cut out the middleman. Effectively, you will place the anaesthetic directly into the cancellous bone. You still get diffusion out through the cortical plate, through the same Haversian system and the Volkmann canals, and all of the periosteum around the dental alveolar structure will be instantly anaesthetized, and with it, therefore, all attached gingival tissues. So all tissues cervical to the mucogingival junction, 360 degrees around the teeth, will be fully anaesthetized. This means, effectively, once you've delivered the anaesthetic, you can remove a tooth, if you choose to do so, immediately. Place a band. Manipulate gingival tissues. Some more examples of Dr. Patil's excellent photography. Extraction of upper left 2. Just to give you the example. You have stage 1, mucosal blanching. Stage 2, penetration through the cortical plate. And stage 3, delivery of the solution. Immediately, with no further anaesthetic delivery, that tooth can be gently removed, leaving a clean, good, excellent hemostasis in that socket. The patient will leave with no numbness of their face, having been in the chair for a very short period of time. In Santosh's case, this was 3.5 minutes from beginning to end. I have equally removed 5 remaining teeth in a full clearance with a single injection in the midline in 4 minutes. And that was because they came out extremely easily, because they were very periodontally involved. But basically, it can be embarrassingly swift, which is good for our patients and us, because no patient that I've ever met wants to spend more time in the chair. So the way to serenity. Let's look at this as a whole process as a clinical video. So what we got here is a osteocentral, that is down between the teeth, of an intraosseous delivery. Shallow aspect of a special design needle, which I will show you in a moment, creates a residual blanching. That needle, same needle, is now reorientated, now placed up near the crest of the bone, incidentally, so up near the top of the papillary triangle, and that is now delivered through the cortical plate by rotation. And extremely gentle manipulation of the device. No force is necessary for this. It doesn't engage and drag itself in, but just the weight of the device itself is sufficient to drive that very, very gently in through the cortical plate. Once that anaesthetic has been delivered, then the needle can be removed along the access, same with the path of access, and treatment started immediately. No further lingual injections, no supplemental injections whatsoever. Patient feels comfortable and fine. Now, we talked about the inferior alveolar nerve block as being something which is a really comprehensive anaesthesia, but has the disadvantage of the extensive numbness and the potential for failure and the weight while it works. In intraosseous anaesthesia, the equivalent here is what we call the retromolar trigonal injection, and it is identified by a little spot which is medial to the external oblique ridge and lateral to the teeth. And in doing so, by introducing anaesthetic into that bone at that point, which represents the thinnest part of the cortical plate in posterior mandible, you will effectively give the equivalent anaesthesia of an ID block without the numbness at the front, and the anterior teeth will not be numb. So clinically, the pre-anaesthesia has already been done, stage 1. Positive contact with the bone. Warning the patient there will be a little buzz and a little vibration, and the needle rotates. In this case, at this part of the jaw, it will only take a couple of rotations, and the moment it drops through, stop. You do not need any depth because you've gained access to that container, which is the mandible. Implant surgery was an absolute dream for me. Really quick, really efficient. Dr. Patil here is using a guided technique to place an implant with just intraosseous anaesthesia. Simple as that. No palatal, nothing there which is going to give the patient any distress whatsoever. And I think he'll agree it's an extremely swift and fast process. So I was writing a list of all the things which I felt I used it for, and then I remembered that actually I threw in all my other syringes away. So it's basically everything. How can it be painless? How can it possibly be painless? Is it you're driving a needle into the bone at 15,000 RPM. This is how it's painless. The Effitech needle, which I said I'd introduce you to, is specially designed at the tip. It's not a point any longer. It's a long, shallow bevel, and then there is a little back cut which renders a scalpel. In effect, what we're going to do is place that needle tip against the tissue, flat against the tissue, and just push down very lightly as if we were going to bend the needle. Start the drop by drop delivery, and it is most often the case that that blanching starts to spread. So you can see with this needle, it's not actually a matter of injecting it into the tissue. So a very shallow angle, which works very effectively with thin biotypes, for example, because ultimately we want to stay away from periosteum, which the patient will feel at that point because there will be no effective anaesthesia. The needles come in 3 formats. The standard protocol white needle is a 30 gauge 16mm needle. If the cortical plate is a little thicker or the bone is denser, then a more robust 27 gauge 16mm needle will also perform that in exactly the same way. For pediatric anaesthesia, a very fine 30 gauge needle, which is just 9mm long, is the way to go. We talked about the electronic injection, which really does reduce any feeling of that initial entry into the tissues. And looking at this video, you can see just how slow that device will deliver anaesthetic solution. Very, very gentle into what is very delicate tissues. That's why it's pain-free. Now, the delivery itself, little satirical. This is a exaggerated graph showing injection speed with time, and this is me on a Wednesday night wanting to get home to get to Speedway on time down at Poole. So I will start to deliver with my syringe a little bit too fast, and the patient will feel that tearing of the tissues before the anaesthetic has taken effect, and they might feel, oh, that was a little sore. I'm being English, of course, I will say I'm terribly sorry and back off. But I do want to get to speedway, so I'll go again. Now, that is obviously a gross exaggeration, but the electronic delivery will give you this sort of graph, starting very slow so that the vasoconstrictor has a chance to work and the anesthetic starts to take effect before the main delivery ramps up. So it keeps the pain away from that process completely. So we've got the electronic assisted injection, and with the pens, effectively, you can deliver the anesthetic using a pen technique. There are no clinical controls on the device whatsoever. These are all setup controls and indications, but all of your focus can be on your patient. So holding it like a pen will give you the ability to make the finest of changes, the finest of advances as necessary. You can be delicate and supportive of your patient. So gone are the days of the mile and a half away from your patient. Now we have what the pediatricians will call the circle of safety, very reassuring as a patient. The pen grip with the other fingers of that hand supporting on the patient's teeth, so that if the patient was to move, it's not a problem. You move with them. All you have to move is your eyes. So planning. How do we plan these cases? First of all, it's a combination of radiographic assessment and clinical assessment, looking in the mouth. Let me give you an example. On a radiograph, you can see many areas here with the little green dots where there is plenty of good vascular bone volume, and those will all be really good places to go. But a radiograph will also show you where it is perhaps less advisable to go. Now, in this case, this is where roots are close together. It may be a root that is much more bulbous, and you may look and see a nice path down initially, but the root starts to converge on the area where you want that needle to remain, which is about 12 millimeters in. So, useful tools. I've got rules. I've got several rules. One of them is that if you can see a space, an area of bone on the radiograph, there is an area of bone on that radiograph. If you can't, as in this lower left 6 and 7, if you can't see one, it doesn't mean to say there isn't one. So look clinically, or look at another view. This is exactly the same patient, and you can see that perhaps there was an angulation of the plate, or maybe just curvature of the jaw, or a combination of the both. But all you have to do is combine radiographic and clinical examination, and you will find a beautiful place to get that access to the cancellous bone. Anesthetic products, we've got a number we can use. The protocol standard would be your 4% articaine in 1 in 200,000 adrenaline. Now that will give you a complete serenity for about 30 to 45 minutes. Plenty enough to do routine conservation work, but if you want a little longer, and I did a lot of CAD/CAM work, so I wanted an hour plus, I might have chosen the 4% articaine in 1 in 100,000. That's going to give me 45 to 60 minutes. I've known that go to 75. Human variation will always be a factor here. And the endodontists will absolutely love the 2% lidocaine in 1 in 80,000. The only thing you need to make sure in that situation is, with the strength of that adrenaline, you do need to make sure you're just in a good volume of bone. That's it. So a summary of the planning considerations can be seen here in Stéphane's triangle. This is my colleague in France. He produced this and I love it. So the 3 considerations will be your site. How close are you to the tooth you're going to be treating? If you are ideally really very close to it, then you will probably need the tiniest volume of solution. Quarter of a cartridge will give you plenty to do conservation with full anesthetic effect, 360 degrees around the tooth on the gingiva. If you can't get close to the tooth you're treating because there is pathology present, or because an anatomy of the structures around that area are contraindicate that, then all you do is increase the volume you deliver. In doing so, you will push that solution just further into the bone. Then you've got the vasoconstrictor concentration, the 1 in 200,000. If you've got a hotter tooth or you want longer as far as you're working, you could use the 1 in 100,000. And then, of course, there's the 1 in 80,000. So I must say, dental equipment in anaesthesia now has evolved. And we've got 3 products from Dentalhitec which I have used. The ultimate one being the quick sleeper there shown at the bottom. The advantages will be for the patient, no pain, completely pain-free, no after effects, no collateral numbness. It makes it extremely easy, and patients will express this to you, as you'll see in just a moment. But there'll be calm patients who no longer fear the dentist, and if it's their first time they've had an anaesthesia, they will have no reason to fear dentistry in the future. For the dentist, you can quite imagine that it's a longer list of advantages. You will have effectiveness even on hot mandibular teeth. This is a great ROI, a good return on investment. Immediate action. You save a lot of time. Now, I will also say that one of the big changes that I was able to make, where before we all have emergencies that are thrown at us during the day, and in a full list, it can be quite frustrating trying to find the time to deal with them. So commonly, maybe I would have once given a block, having diagnosed and consented with the patient and planned the treatment, and then they would sit outside for a while. That never happened again for 14 years because of the immediacy of the action. I could just simply deliver the anaesthetic, do the emergency treatment, and I'd be back to my day very, very efficiently. So that's another big return on investment for me. My stress levels, can't even put a price on that. That has got to be a return on investment from the start, because I was much happier myself. The stress you feel when you've given a block, the patient has got the numbness to the front and they think, I think I'm ready. And you start work, you've looked at the radiograph, you've seen that the amalgam is so deep, and you know as your air turbine diamond gets to the bottom of that depth, you're just out of the corner of your eye, just watching the patient's eyebrows. And what happens to everyone when the patient goes, ah, and they felt it? Everyone now has got stress levels that have spiked. The patient now thinks, oh my goodness, I'm going to be experiencing pain here. And their awareness of pain will have jumped very high. Your stress levels have gone through the roof, because not only have you compromised the relationship you have with your patient, but also you now know you're going to need to find another way of anesthetizing this tooth. And that is going to take more time. So time, remember, is a big stressor in our working lives. Your nurse also may well be very stressed at that point, and of course your team outside will be dealing with patients that are now being kept waiting. So take all of those factors away, what a bonus, hey? So no post-operative side effects, and then very cost efficient. Cost efficient because the operating costs are just one cartridge, which you'll never need more, and one needle. So gone are the days of multiple cartridges. The first one is going to work. So that's an investment return. Appointment optimization and the management of emergencies, as I've just described, is real. And your reputation, it's a real true USP. It's a unique selling point for your business, and patients will go out and they will tell others, and they'll come back and they'll say, could you use that electronic magic you used last time, which has no needle, because they often don't suspect there's a needle either. So I never lie to patients, but I'm always perhaps a little careful with the truth. So they may turn around at the end and say, that was amazing, I just don't feel anything that's happened, and no needle either, because they haven't felt any sharp prick, and you haven't shown them the needle. And I don't say, oh no, there was a needle, but what I will often say is, yeah, it's good, isn't it? And it's a real practice builder. So that is another return on investment. Let me encourage you all to take advantage of your patient's first reactions. Your patient's first reactions will undoubtedly be extraordinary. I'd like to introduce you to Christine. Christine was a patient of mine since she was a young lady. And she, just to show you how long ago this was, she now has teenage girls of her own, which have now, in fact, left university. So they've grown up and gone. So this is how long I've been looking after her teeth. But Christine is a lady who, one of those ladies who always seemed to need something doing. She'd had multiple inferior dental blocks in the past, and she came in about 12, 13 years ago, and she sat in the chair for a class 2 restoration on a mandibular molar. When we finished it, I used that intraosseous anaesthesia for the first time. And when she finished, she sat up to have a rinse, and she just made this little noise. And I said, "Are you all right, Christine?" And she said, "Yeah, I just like, what have you done?" I said, stop. I said, "If I hold this iPhone, would you say that again?" And it's a perfect time to do this with all the GDPR signage afterwards. And Christine is very proud that she comes around the world with me. But Christine basically said what you're about to hear. But I'd like you to also look at her lips. She has had the equivalent of an inferior dental block. James, can you hear that?
No, nothing coming through, Andrew. I don't know why.
Okay, my apologies. Just having a quick look, see what my settings are here. Can't see. I will see if I can play that again. No, I must sincerely apologize. Christine, you can see her talking there, but what Christine is basically saying is she's just had a quick sleepy used, and she quite extraordinarily doesn't feel like there is any feeling that I've done anything. She said it's really fantastic. My apologies for that failure there. Another thing I want to make a note of is that the process of the delivery of the anaesthetic is incredibly calm. It can create a very great peace within the surgery, and it appears to be a long time. What I want you to think about before I show the next video is, which is in real time, of a very similar process that Christine had. And I want you to think about how long it would normally take from first needle contact with the tissue for a block to do a posterior mandibular class 2 restoration. I did this in real time because I wanted to show how fast it was. And this was the speed between first contact of the needle with tissue and finished preparation of the cavity. So I'll talk over this if I can, because again, the sound is not majorly significant. So we've got that first stage, the mucosal anaesthesia, and that is extremely gentle. You'll notice from this is Christina. Not all my patients call Christine and Christina, but this was Christina, and you can see there is no jarring or movement of her, so there is no feeling at all. This was actually done with a film crew in the room, and it was important I got this right because she was interviewed straight afterwards. So that first residual stage creates residual blanching. I then reorientate myself, and I take the same needle, same device, I haven't put it down, and I now reorientate it to make positive contact up at the top of the papilla. I can advance that now through the soft tissue until I make positive contact with bone. I then quite simply tell Christina that there will be a little buzz, a little vibration, and I know it's coming effectively now. And that rotation is intermittent. You don't have to do that. You don't have to press and release the button. The computer and the device does all of this for you. And that will gently, you'll see, deliver itself through the cortical plate. And then there's a little drop there you saw, and it delivers it into the cancellous bone. 12 millimeters in now. I can now relax and tell Christina that we're going to just spend a little bit of time while this electronic device makes her tooth fully numb. I talk a lot during this stage, but it's all very calm. I use my calm anesthetic voice. It's quite a Zen-like atmosphere during this phase. I tell her that there may be a slight increase in heart rate because of the adrenaline that is going into a highly vascular and indeed microvascular tissue. And then we can watch on the device as the anesthetic solution is delivered. I also make a point of telling patients that this electronic device will make the anesthesia profound and immediate. And I tell them this for a very good reason, because I tell them that we will be able to start work as soon as I finish. And you'll see this in just a moment. This has mercifully stopped any patient who you can imagine is used to ID blocks, and I finish the anesthetic and they don't feel numb at all. And you can imagine that if they didn't know that this was profound and immediate, then they might well say, whoa, you stay away from me, I'm not numb yet. But I mercifully have no one who's ever said that to me, which is great. So we're getting now I've delivered a full cartridge. So that takes about a minute and a half. As I said, serene and calm. The speed lies in the fact that it's predictable, you'll never have a failed anesthesia, and you get straight on with it. So in a moment, that device will just beep and stop. The little light will show that it has it's fully delivered the cartridge. And you'll see that the moment I do that, I withdraw the device. There it is, very close to the end now. And as soon as I withdraw the device, you can see me putting it back. I wanted to do it in real time, so forgive the fact the camera's moving all over the place because it's attached to my loops. And you can see how confidently I start work. So the beep occurs now. I withdraw the needle, safe resheathing, pop it back into its little holder. Becky will now know that I'm about to start straight away. So the aspirator effectively comes on and I move into position. And you can imagine now we'd be waiting for the block to start. But I am happy to go straight in and start work, knowing that Christina will feel nothing. You can see as soon as the old restoration comes out, that I'm straight down onto dentine. And that's something that before I would have been hyper conscious of. I would have been watching her like a hawk in case that accessory innovation overrode the inferior dental block and she would have felt something. So I continue just to prepare that cavity. And as soon as I've done that and inspect it, I can tell you that the entire process from first needle contact to finishing of that cavity, and I'd like you to remind you to think about how long you felt that would have taken with a block. So checking there, the whole process effectively was 5 minutes and 16 seconds. That was the point at which I was able to place rubber dam, band, and start to fill that, restore that tooth. That is why I have had such pleasure in using intraosseous anaesthesia and controlling my day. And because I wasn't worried about her feeling anything, there was no doubt in my mind that I was going to give her any discomfort or pain. Representing as I do the Dentalhitec Academy, we are here and will support you into the future with training. It is does take a little learning curve. I personally, in the first month of my use of it, I made quite a number of little mistakes. None of them harmful, because the device is very much set up with its computer in there to ensure that you do not do any damage to your patients. I'm talking here the pressure. If it feels there is increasing pressure in the tissues, it doesn't just keep pushing or indeed push harder, it actually backs off. So these are little things that I tripped over initially, but they were explained by my trainers. And this is Eric from France, who was, he calls himself my spiritual father, and I'm his spiritual son, but certainly my gratitude is huge towards him. So I continue to charge all around the world, telling everyone about it, and I am here very much to support you in the future as you start using this device, which I cannot recommend highly enough to you. So James, that is my presentation for this evening. Can I ask you to just see if we have any questions? And of course, you can put those questions in the Q&A now, and we can address them.
Yeah, thanks for that, Andrew. That was brilliant. And yeah, it's worth pointing out, if anybody found this interesting and would like to know a little bit more, we've got a number of training days. They're free to attend. I think we just take a refundable booking fee. It's refunded on attendance, but we're at different locations around the country, so you can come and find out. And we spend a whole day. You can experience it, try it out, have it used on yourself if you want to see exactly how it feels. But you can access those through the Swallow website. But yeah, there's been some good questions. So the first one, Andrew, was it was from Araz, and he's asking, in terms of explaining the technique to patients, how do you? Because he was saying he thinks some of his patients would be extremely anxious about the idea of having a needle being drilled into their bone and so on. So how have you dealt with this in the past?
Very, very good question. Frankly, I like to use the analogy of using an air turbine and a red ringed electronic high speed. Do you ever talk to your patient about, now in this situation, I'm going to be using my electronic handpiece rather than my air turbine? The answer, quite frankly, as you won't surprise you, is no, you don't. I believe firmly that no explanation is required as to how the device works. What I will say to the patient quite clearly is, right, we're going to make that tooth numb now. They're used to that. Anesthetic happens with all cases, or most cases. And they will lie back, and I will then continue to talk to them about what they're going to feel, not what I'm going to do. You're absolutely correct. The last thing I would do would be to say, I'm now going to rotate a needle into your bone at 15,000 RPM. They wouldn't stay in the chair for very long. I'm absolutely with you there. So what I say is, stage one, I say it's going to be a little pressure on the gum. And indeed, that's all they feel. And then that goes. And it's literally pressure like you were with a finger. It's just like a little touch. Then when I come to stage two, I will get into my position, and then I will say, now there'll be a little buzz, a little vibration. I tell them to, because one's a sound and one's a feeling. And you can bet your bottom dollar that if you say one and not the other, they'll jump at the other. So I say there's going to be a little buzz, a little vibration. I know when it's going to happen because it will always start the rotation exactly 2 seconds after the beep as you press the button to start that. So no, I don't do any explanation. A lot of the explanation happens as I described with Christina's case during the process of the clinical act, and then afterwards. It is very, very often, especially at when they have it for a first time, that there will be a conversation, because they'll say, "What have you just done? That's extraordinary. I just don't feel I've been there." And that is an interesting one, because that's when you can just say, "No, we've got an electronic device which makes you numb without any worries of a numb face." I hope that answers your question. Basically, I don't tell them that I'm doing anything special. I certainly don't say, "I've got this new device which is electronic and it's going to be magical," because all you've done is you've now heightened their awareness. Don't do that.
That's great, Andrew. Thanks. There's another question asking about indications for whether you use infiltrations or other methods of anaesthesia rather than intraosseous?
Great. I'm speaking purely from my own experience, but also with a view to others that I have trained and my colleagues in the Dentalhitec Academy. Effectively, I would say I analysed that 96% roughly of my dental clinical acts were intraosseous. It's because it is pain-free. It's because it doesn't have any side effects. It's because it's immediate, predictable, deep. It just works. It's so wonderful. The only times I would ever use just soft tissue, and I would never use a syringe again, because the device itself has settings which will allow you to do traditional anesthesias as well, but with the advantage of the Effitech needle being pain-free entry and the electronic delivery having all of the advantages that I described earlier. Effectively, I will still use this, but it will be in situations where it's just soft tissue manipulation only, so I don't need the intraosseous anaesthesia, and on very, very rare occasions where there just isn't a good effective access to that bone. With regard contraindications to using intraosseous anaesthesia with any patients, I think that's a pretty easy one to answer, and that is because the complications associated perhaps with a patient on long-term IV bisphosphonates is to do with the actual clinical treatment itself, not due to the anaesthesia. I would say to you categorically that the contraindications for use of intraosseous anaesthesia are no different from the contraindications for using traditional techniques.
Excellent, thanks, Andrew. And another good question: how high is the risk of needle fracture? And if it happens, is it high enough to require taking written or verbal consent from the patient, and can it be predictably retrieved when it happens?
Great questions. That's a really good forward-thinking look at this. The answer to your question is that from my experience, I will admit to you all of my errors, and I've made a few in my time. I have broken in those 14 years about 6 needles, and they all happened in the first month. Why did they happen in the first month? It was before I perfected the protocol, the actual performance of my protocol. And the protocol involves multiple finger contacts, which may sound obtrusive, but every single finger is involved, and effectively that means that I can control the device relative to the patient's face. If the patient moves, it moves. Now it moves with the patient. So you may a really good example there would be a patient with advanced Parkinsonian movement. If they are moving like this, you're thinking, how on earth am I going to get a precise entry? And the answer to that is easily. All you do is get that lovely support points, that ring circle of safety, and all that's tired at the end of that appointment are my eyes, which have been flicking all over the place following the needle and the patient's face. Breakage does happen. Breakage does happen, and I broke, as I said, 5 or 6 needles all early on. Once the needle has started to penetrate into the bone, it is very well protected. All of the flexion that might occur if your device goes offline relative to the patient and relative to its rotation in its long axis, which causes needle flexion, that could cause the needle to break, but it will always break when where it is flexing most, which will be up at the hub. Did a patient ever know I'd broken a needle? No, they didn't. And it's not because I hid anything, because it never had any consequence. If I did not have good support and a needle broke during the rotation, then all I would do is just calmly put the device down, never even moving my left hand, being a right-handed person, and I would say, Becky, could I have the mosquitoes, please? She knew what had happened, so she would just pass me the mosquitoes. You could take it out with your fingers, in theory, but of course I'd never teach that. But a little pair of mosquitoes, grip the tip of it. There will always be 4 millimeters showing because you never, by protocol, deliver that needle down to the hub as you wouldn't with a block. So no different again. And I would remove that, clip it, pop it on the top, and say, Becky, there's a sharp up there. She, in the meantime, has walked round, changed the needle, haven't moved my hand. I've picked the device up again with the new needle, and I'm back in. And the patient would never have known there had been a breakage. I certainly would never stop and say, oh my goodness, I've broken a needle, I'm so sorry. If there was a situation where there was any sort of long-term consequence, then of course, that's when you would be talking to the patient and explaining what had happened and what you were going to do about it. But no consent has ever been considered necessary because it will not have a consequence.
Thanks, Andrew. It's telling us we've got about 3 minutes left, so we need to be fairly quick. Kelly asked, do you place...
I'll try and answer quicker.
Yeah, Kelly asked, do you place topical local anaesthetic before giving the initial?
What a great question. No, categorically no. I'm working at the moment, most of my time is spent with the pediatric community in the US, and they of course have got an entire protocol with their traditional techniques where topical is always put on, and they don't have to negotiate in or explain this to the patient. It'll be the parent they have to explain it to, but basically I'm telling them they don't need it. They do not need it. And my pediatric doctors that I'm training in the States, they are now, when they're first using it and they're on a patient who has never had an injection before, they're not using it. But I always tell them, if you want to put it on as part of the protocol to keep the parent happy and to keep everything the way the patients expect it, then you could always use it, but there's no need for it. No.
Brilliant.
Great question.
Next one, can dental therapists administer intraosseous local anaesthetic?
Okay, really good question. I have been working with the GDC on the new scope of practice document. I have been interviewed and I have made it clear that this is something that dental therapists and indeed in certain circumstances I've had dental hygienists who've been on courses and I believe firmly that with appropriate training they should be able to use it. The GDC's position is that they are happy for any clinical professional to go off standard pieced as long as they are trained, certified and indemnified. That is their stand. So what we've got to do next is speak to the indemnity people, because we can train and we can certify, but what will be the flexible bit is whether your indemnity company will cover you for that. I hope that answers that question.
Excellent. Any questions that didn't get answered, we'll pop them out. There'll be a follow-up email to everybody who registered, so we'll try to make sure that it all gets included on there. But thanks everybody for joining us this evening. I hope you found it interesting. Hope you found it useful. Andrew, thank you so much for your time tonight. It's been great.
You're welcome, James.
Thank you very much.
Enjoyed it.
All right, I think we've just got in there before the clock strikes 8 o'clock. So, like I say, any questions, we will try and answer them in the follow-ups. Okay.
And this has been recorded, hasn't it, James?
Absolutely.
So people will be able to get a link to this recording to either watch bits again, or indeed anyone who has missed it will be able to see it.
That's it. Okay. Perfect. Thank you very much.
Thank you all very much indeed. Have a lovely evening.
Yeah. Same to you. Thanks a lot.
Bye-bye.